Hello, my name's Hugh Wheatley. I'm an ENT surgeon based at Gloucester Hospital's NHS Trust. My role is to diagnose and treat patients who have head and neck cancers. So as we talked about last time, we do have a cancer in the throat region. We've had a look at all the scans, talked about the pathology this morning at our MDT meeting, and we feel the best treatment for you will be a course of radiotherapy. The radiotherapy will take place at the Oncology Centre at Cheltenham General. The radiotherapy is delivered by my radiotherapy colleague, Dr. Cook, and we'll take you through to see her shortly. The course normally lasts for a few weeks, but Dr. Cook will be able to go through that in great detail with you. When the course is finished, we'll normally see you a few weeks after that, and then for the first year we'll see you every month, second year every 2 months, third year every 3 months, then every 4 months, every 6 months for the fifth year, and after 5 years, hopefully that'll be the end of it, and we'll be discharging from the clinic.
Hello, my name's Vicky.
Hello, I'm Laura Kent and I'm a head and neck specialist dietitian.
Hello, I'm Jo Payne, I'm a head and neck specialist dietitian.
Hello, my name's Dr. Louise Foster. I'm the consultant in restorative dentistry.
My name's Elaine Pratton. I'm a cancer research nurse.
Hi, my name's Jan. I'm working in the radiotherapy department at Cheltenham General Hospital.
Hello, my name is Liam. I work at the radiotherapy department in Cheltenham.
My name's Ian. I'm one of a team of the radiographers that you will be seeing during your treatment.
Hi, my name is Joanna White and I'm a Macmillan specialist speech and language therapist in head and neck cancer.
So we'll get you through to see Dr. Cook now, and she'll be able to tell you all about the radiotherapy. Best of luck with that. I hope it all goes very well for you. We'll then, when it's finished, we'll see you back in the clinic in 4 or 5 weeks after the end of the radiotherapy, and then that will start our follow-up for the next few years to make sure the disease has gone away.
Hello, my name's Dr. Cook. I gather you've already seen one of my colleagues and explained that you're going to need radiotherapy treatment. So I just wanted to run through with you what's involved with that. As you may know, it's going to be 6 weeks of treatment, and that's every day, Monday to Friday, which sounds quite daunting, but you're only in the room for about 10 or 15 minutes each day, so it's a short treatment each day. The first thing we do when we plan your radiotherapy is we need to make a mask to fit over your head and keep you in the same position each day, because it's obviously quite vital that everything lines up in the same way. Once we've made the mask, we do a CT scan with the mask on so that you're in the position that you're going to have radiotherapy. And I use that to draw on the bits that I want to treat and the bits that I want to avoid. And we spend some time getting the best plan to fit you. The treatment itself is quite painless. You don't feel anything. It's like having an X-ray done. It's just a powerful form of X-ray treatment. Most people find though that for the first few weeks they feel fine, but then you may start to get some side effects. In some cases, and in your case this is true, it can be useful to give chemotherapy treatment at the same time as the radiotherapy. And the reason for that is it's actually helping to work with the radiotherapy and make it more effective. Not everybody needs it, but in some people it can be beneficial. And if we do give chemotherapy, we give it twice during your radiotherapy treatment. So we give it usually at the beginning and halfway through your treatment. And when we give the chemotherapy, that's given into the vein. So chemotherapy is a treatment that circulates around the whole body. So it has slightly different side effects. First of all, it can make you feel a bit tired, a bit washed out. It can make you feel a bit sick, but we do give you strong anti-sickness medication beforehand. The chemotherapy can affect your kidneys as well, so we need to give lots of fluid before and after. So we tend to keep you in hospital overnight, the day that you have chemotherapy. And we'll also do a special kidney test to check that your kidneys are working 100% before we start. But we'll go over all of these things again. And we do usually organise a special pre-chemotherapy appointment to meet one of the nurses giving the chemotherapy. And as I say, organise that special kidney test before you start. So it is quite a long haul, but the important thing is that we're aiming in most cases, and certainly in your case, we're aiming at trying to get rid of the cancer completely. And so it's going through all of this, but with that in as our aim at the end of it.
Hi, my name is Joanna White and I'm a Macmillan Specialist Speech and Language Therapist in head and neck cancer. So all patients before they start their radiotherapy or chemotherapy treatment will come and see a speech and language therapist to assess their needs during treatment. I get a lot of people who say, well, why have I got to see a speech therapist when actually there's nothing wrong with my speech? Well, my role is actually not what my title says. So my role is primarily, although I do work with people who've got speech problems after, say, having parts of their tongue removed or their soft palate removed, my main role actually is to do with eating and drinking. So I will assess somebody for how their swallow is before they start treatment, and we will give advice about how to maintain their swallow during treatment, because we know that people who continue to eat and drink during their radiotherapy will have a far better outcome long term in terms of their swallowing rehabilitation. So we assess and we give advice about what to eat and drink, and we also look at the voice, and then virtually all of our patients will be given advice on a condition called trismus, which is where the radiotherapy beams pass through the jaw area and can cause some fibrosis in the muscles, which mediate whether or not you can open and close your jaw. And that's a process that can continue for up to 9 months after treatment, with this sort of really slow closing down of the jaw. So what we'd like to do is give people exercises before treatment to get used to them, so that they are doing their exercises regularly, and that they will then continue on treatment and then 9 months post-treatment to try and prevent this jaw closing up and becoming a problem. They're really simple, and people think, you know, is this enough? Because they are so simple. I'll go through them in a bit, but literally it's to do with just opening the jaw to the greatest extent that you can without causing pain. You should feel an active stretch, a bit like you've gone to the gym and done a jaw exercise, which you would never do. But it's that sort of feeling that, you know, you're at the gym and you can feel a nice active stretch, but it shouldn't cause pain. And you just do those on a regular basis to try and break down. During radiotherapy, the beams passing through cause some proteins called fibroblasts to form on the muscle fibres. And what you're trying to do is break down those fibroblasts by moving the jaw in a normal way, and really stretching it so that they can't become established and cause the muscle to become fibrosed and unable to move effectively. So trismus is a condition which I think a few years ago was one of those condition side effects that was seen as just something that patients had to just accept and get on with, and actually that's not the case. It is preventable. It's certainly treatable as well if for any reason you get a trismus, which is, the definition of that is 35 millimetres or below of jaw opening. I will measure it when people come in to see me, and I can give measuring devices if people want to measure it themselves at home. And I'm just going to find your lower tooth. Lower tooth. Oh, blimey, all the way down there. 40. Oh my lord, it's getting bigger. 50 mil. 35 mil is seen as the definition for a diagnosis of trismus. I personally don't really think that's a very accurate measurement. It doesn't take into account size, gender, age. I wouldn't necessarily expect a young man of 6'5" who is 13 stone to have a jaw opening of 35 mils. That wouldn't be very large for him. Whereas an elderly lady who is perhaps only 5 foot and weighs possibly about 7 stone, a 35 would be huge on her face. It just wouldn't be in proportion. So I think measuring the difference over time of the change is most important. But what's actually really important is 25 mil. So I've been really boring. And I've been round and I've actually measured people's food as they put it into their mouth. So they've got their sandwich and they went to put it in their mouth. I went, stop, I want to measure that. And I reckon that 25 mils is far more functional. So if you've got 25 mil or above, you're probably going to be okay to eat most things. You're going to eat a ham sandwich without too much salad in it, or you're going to eat a fork full of peas or something like that. But if you get below that 25 mil, then it can cause real problems with things like opening your mouth to talk, cleaning your teeth, which is obviously really important, particularly post-radiotherapy, speaking, and particularly yawning. So yawning can be a real frustration for people who have established trismus. They try to open their mouth for a nice big satisfying yawn and they just can't do it. And it can be really frustrating because they just find it one of the biggest annoyances. So I feel that if we can prevent trismus from happening, then that's a far better thing to do than to allow it to happen and then have to treat it, which is far more difficult.
Hello, I'm Jo Payne.
And I'm Laura Kent, and we're head and neck specialist dietitians. So, depending on treatment, you may be advised to have a temporary feeding tube placed before your treatment begins. So this is what a feeding tube can look like. So a feeding tube will allow water, liquid nutrition and medications to go directly into your stomach. So this doesn't interfere with your normal eating and drinking, but what it does mean is you don't have to rely so heavily on swallowing your food and drink to maintain your nutrition and hydration during your treatment if your mouth or throat becomes too sore. So as a dietitian, we can advise on the nutrition that can go through the tube and also the different ways that we can actually give you the feed, as there's lots of different methods that we can do. So for the tube to be placed, you'll need to be admitted to the ward for the procedure, and you'd need to stay afterwards so the ward staff can train you in the use and care of the tube. So once you've gone home, you'll get a regular delivery on a monthly basis to your home for all the feed and equipment that you might need, and you'll have support from us as dietitians and also our home enteral feed team if you have any problems that you might experience.
So all of the side effects can make it very difficult to maintain your oral intake and put you at risk of losing weight. You'll be seen regularly by the dietitian to help support you with this and help you make appropriate food choices. The dietitians can also advise you on the appropriate use of nutritional supplements. So you'll be seen on a weekly basis as you go through radiotherapy treatment, and you'll be seen by a dietitian before the treatment starts and then afterwards as well. Some of the side effects that you might experience might include a dry mouth, sore and painful mouth, difficulties with your swallowing, taste changes, constipation and occasionally nausea. So all of these side effects can make it quite difficult to maintain your oral intake and put you at risk of losing weight. As a dietitian, we can help support you with these changes and try and maintain your intake as best we can.
Hi, my name's Jan. I'm working in the radiotherapy department at Cheltenham General Hospital.
Hello, my name is Liam. I work at the radiotherapy department in Cheltenham, and today I will be a willing volunteer for a mask fitting. Normally I make the masks for patients who are due for radiotherapy treatment. The reason I'm being the patient today is to enable me to know what it is like to be the patient in this scenario and enable me to support patients when I come to making their masks when they come in for treatment.
So the mask starts out life as a flat piece, and we put it in a tank of hot water and it goes up very malleable. Best way of describing it is a bit like cooked pasta, really. We need to get you lying on our bed nice and straight, and we'll use laser lights in order to do that come from the sides of the walls. So the laser lights will get you nice and straight. We'll be putting some marks on your head just with a black felt tip pen mark, and that's just to help us line you up. It is quite hot when it first goes on because it's in a tank of water, but we do shake it off and test it with the back of our hands before we put it on you. You are actually attached to the bed, so these click down and attach you to the bed. Myself and whoever's helping have about a minute and a half to mould it in around all your features. We just need you to lie nice and still, breathe away normally and try and relax as much as possible. We then need to leave it to set, and it takes unfortunately 15 minutes for that to go back to being hard. We've got a timer going so we can count you down. Obviously you can't talk while you're lying on the bed, so if you give us a thumbs up or a thumbs down as to whether you're okay or not. We'll be in the room with you all the time, so just try and relax and we'll get you through this. Once we've made the mask, you then need to go through and have a CT scan with you wearing that mask, and we'd ask you to leave those marks on that I've put on. We would ask you to remove any dentures you've got. So if you have dentures, then we need those out. And we'll need you to undress from the waist up, and we'll give you a gown to put on.
The time does go slowly, but because you're supported by 2 members of staff constantly talking to you, you do feel at ease throughout the procedure. When we see you in the radiotherapy department, we will do our utmost to ensure that your treatment and the procedures go as well as possible, and it's tolerable for you.
Hello, welcome to oncology.
My name's Ian. I'm one of a team of the radiographers that you will be seeing during your treatment. First day you're here, we will be taking you through into the room shortly. What we're going to do is get you laid on the couch the same as you were when you came for your CT scan. We'll need your top things off, and then we'll get you laid down, and we will gently lay the mask over and see how you get on with that. If you're okay with that, we'll gently fasten it down. Once you're fastened down in the mask, we'll make sure that the little marks that are on the mask line up. Turn the room lights down, lasers are going to come on, and we'll set you up to those marks. We'll be talking to each other over the couch, so it'll be me and a colleague in the room, we'll be talking to each other as we set you up. And if there's any problems throughout any of this, just raise a hand and we can pause and make sure you're okay. Once we've set you up to those marks, we will be calling out some numbers, and you might feel the couch move underneath you a little bit. That is us moving from the reference point, those little dots, to the point where the doctors are marked out for treatment. When we're happy that you're in the right place, we'll leave the room and we'll be ready to do the scan. Now, the reason we do a scan is to check that whilst we've got the plan and the moves and the setup, the scan checks that it's in exactly the right place for treatment. The panels come out either side of you, the machine's going to rotate around you, and then it'll go around you again and naturally deliver the scan, and you'll hear the machine buzzing away. Then it's all going to go quiet for a few minutes whilst we check those images that we've taken. Once we're happy with the treatment, the gantry will move around you again and we'll deliver the treatment either in one continuous burst or from different positions on the way round. That all takes about 2 or 3 minutes. Once we're done, we'll come back in, let you out of the mask and bring you back down. And then you'll be free to go.
So we'll see you on a weekly basis along with our review radiographers, just to help you with any of the side effects that might come along as you're going through the treatment. One of the things you might find is your mucus might thicken up, and one of the things we can do if that is the case is give you something called a nebulizer, which will help thin the mucus down and make it easier to get rid of. Sometimes we can loan you one of these from the radiotherapy department, but otherwise you can get one on a short-term loan from your GP.
We do suggest putting in a tube into the stomach, and not everybody needs that, but if you have the stomach tube, you can feed yourself at home and just keep your weight up and keep your strength up, really. Sometimes people still struggle a little bit with certain foods. You still may have some degree of dryness of the mouth.
One of the main things we want you to do as you go through treatment is to keep swallowing, just to keep those swallow muscles working. And again, you'll have seen our speech and language therapy colleagues who might have well given you some exercises to encourage you to be able to do that. And keeping eating, swallowing will just make your rehabilitation after treatment that much quicker. We know it will get sore as you go through treatment, and one of the key things to do is take painkillers. People are often a bit frightened of taking pain relief, but this is quite a unique situation you're going through. So do let us know if it's sore. We would like you to start taking paracetamol, and if that's not enough, we can build that up to something stronger. So do let us know if that's becoming a problem. One of the other things that can happen as you go through radiotherapy is your skin can become quite sore. We know this is likely to happen. It's just things you can do to prevent what level it happens at. Don't kind of rub it or be harsh with it, just pat it very gently. And if you can start to use a moisturising cream on the weekend before your treatment starts, that will put the moisture back in your skin the radiotherapy is taking out. That being said, we do know that you're likely to get a skin reaction towards the latter part of your treatment, and if that's the case, you might well use something called Polymem, which is a dressing, and the girls on the treatment machine will be checking your skin each day when you come in for treatment, and they may well use this Polymem dressing for you. So it can come on a roll, which looks like this, and that can just be wrapped around your neck, and it's got properties in it that can help with the healing. As you go through treatment as well, you can start to feel tired, particularly if you've had some chemotherapy as well, and it is just listening to your body and just resting as you need to. Doing a little bit of gentle exercise can help combat that fatigue, but it is very much resting as and when you need to. Some of these side effects can continue for a little while after you've finished treatment, and again, myself and the dietitians and speech therapists will see you 2 to 3 weeks after treatment finishes to help guide you through what can be a slightly difficult time. And it can be a little bit disconcerting because although you're pleased to finish your treatment, you don't have that reassurance of coming in and out every day and being seen by professionals, but we all are still around on the end of the phone if you do need to contact us. There are a couple of things that we do to help you through the recovery as well. We do a Living Well Day, which we do once a year, and you will get an invite to that. And also we do a shorter programme over at our Maggie's Centre, and again we'll send you invites to that. But the key thing to remember is to let us know if and when you're getting problems so we can help you deal with them as they come along.
Hi, my name is Simon and I'm a cancer survivor. The thought that I might even have cancer hadn't really entered my mind, not least because a couple of weeks prior I'd also had a blood test. I was going on holiday and I'd asked my GP about these sorts of things, and having had a blood test, the results came through prior to going on holiday that my bloods were clear, so it suggested that everything else of that magnitude was okay. I wish I'd sort of plucked up the courage to break the news a little sooner, because I think bottling it up just accentuated the difficulty with actually coping with that level of information and diagnosis that you're given at the time. And in hindsight, that was definitely a mistake, and something I'd recommend to anyone else that they don't do. That the first thing you really should do is break that news, share that news with your nearest and dearest, your partner, wife, husband, your children, all of your closest family and friends. And although the treatments and the procedures all sounded quite onerous, the one way I found to actually deal with it was to convince myself at every stage that everything that's going to happen to me is for the better. It's there to cure me. It's not there to hurt me. It's there to help. And if you treat that or take that approach, I think you can cope with pretty much anything that's thrown at you if you have a mind to. To come out of the other side, and within 2 months of the completion of my radiotherapy, to have a consultation which had to look in the affected areas, and came away from that single meeting in January of this year with the view that, you know, the words that Mr. Godden shared with me at the time were, Simon, your cancer is gone, it's all gone, you're on your way. And a tap on the shoulder. I think, to be honest, my wife and I floated out of that room on a cloud, because that's all you could possibly hope to hear, and to hear it so soon, within 6 months of my initial diagnosis and within 2 months of the completion of my radio and chemotherapy treatment, was that was the nicest surprise of all. That was the best New Year's present that anyone's ever given me.
So again, just to emphasise, we're all there for you as a team, with a specialist nurse, dietitian, speech therapist, and we'll be there to support you through all of this. But you know, it can be a tough treatment, but you know, the aim is to get through all of this and to come out the other side successful.
If anything comes up on treatment that you're not sure about, that you can't remember, we talked about, we're always here. ring us. People never do. We never ever get phone calls, but we would welcome that. It's fine, we're here, that's what our role is. We're more than happy to help with any questions, and there is no such thing as a silly question. I've been asked some things in my time that, you know, have perhaps been surprising, but there's no such thing as a silly question. If it's on your mind, ask it.
Hello, my name's Dr. Louise Foster. I'm the restorative dental consultant, and if you're going to have radiotherapy, you will come and see me. When you have radiotherapy, you tend to end up with a dry mouth, and in consequence, your teeth are at risk. You can get a lot of decay in the roots of your teeth, and at some stages, you sometimes need to have your teeth removed. We really try to avoid this after you've had radiotherapy, as you're at risk of a very nasty infection called osteoradionecrosis. Osteo for bone, radio for radiotherapy, and necrosis, the bone dies. When you come to see me, I will take a lot of information from you and I will examine you. I will give you an individual care plan, and this tells you exactly what you need to do to keep your teeth in good condition. If you don't feel you're able to follow the care plan, then sometimes it's necessary to remove the back teeth. And also, we tend to remove wisdom teeth if you can't clean between that tooth and the tooth in front. Teeth that have got severe gum problems and you've lost bone support on, or if they've got a lot of decay in the roots. Wherever possible, we try to do this before you start your radiotherapy, as this minimises the risk of you getting that nasty infection called osteoradionecrosis. After I've seen you, you will then have an appointment with the hygienist, who will go through the care plan with you and get your mouth into tip-top condition. You'll have any extractions that are required done within the hospital here, usually within 10 days to 2 weeks. And then after the radiotherapy, I will review you in about 6 months and then keep you under review for a 5-year period. In the meantime, it's really important that you carry on having dental checkups with your dentist, because I am only overseeing the treatment. I'm not able to do all the routine stuff. I look forward to meeting you to help you maintain your mouth and teeth in good condition after you've had radiotherapy.
So Jill has kindly offered to come and demonstrate the exercises for trismus for us, so that we can show you what to do when you're at home. The exercises should be completed 3 to 5 times a day, and each exercise should be done 10 times each and held for about 3 seconds. So if you'd like to turn your head to the right, so that's chin to shoulder, rotating around to the right, so if I went to the left. Hold it for about 3 seconds and then come back to the middle. With all of these exercises, it's really important that you stop in the middle, because even at really low speed, you can actually give yourself a bit of a whiplash injury. So if you go exactly the same but to the other side and hold it for 3 seconds, come back to the middle and back to the other side again. Perfect. And you would keep going until you've done each side 10 times. The next one is to lean your head back. Only go as far as is comfortable. Don't cause any pain. If there's any pain, stop, come further forward. Then come back to the middle and then head forward. And hold that for about 3 seconds. And then back to centre. The next one is leaning your ear towards your shoulder. So ear to shoulder this time, that way. And feeling a nice stretch down that strap muscle. And then back to centre, and then to the other way. Don't worry if you can't get a very big movement. Jill's isn't particularly big. That's fine. Whatever feels comfortable is more than good. And if you've had a neck dissection, it does make it more difficult to do that particular exercise. The next one is to retract your chin in. That's very nice. Hold that one for about 3 seconds. And then back out again and have a bit of a rest. And then back in again. Keep going. People quite often ask, why are we doing these exercises on their neck when actually the trismus is about your jaw? And the reason is you've got lots of strap muscles which go down your neck, which attach to your shoulder blade and then attach to just behind your ear, that are the muscles that actually keep your head straight on your shoulders. And what we're doing is we're getting blood flow up into the area just behind where those jaw muscles are, warming them up, ready to go. The final exercise in the warm-up is to put your elbows, try to get your elbows behind you to touch. They won't ever touch, but it's just trying to get them as close together as you can so that you feel a nice pinch between your shoulder blades. Hold it for 3 seconds, which you did. Having done that, we actually then move on to your jaw. So we get you to drop your jaw as far as you can down comfortably and hold that for about 30 seconds. I won't make you hold it for 30. And then close it down again. You then drop it down again as far as you can and move it over to the left. It doesn't have to be a large movement. If you feel like you're not getting any movement at all, you can just use your fingers just to gently press on the side which you're trying to move towards. That's absolutely fine. Hold that once again for about 30 seconds and then relax it. You then do the same, drop it down and all the way over to the right. That's good. Everyone will have one better side than the other for the movement. There's no predicting which way is better, but Jill's is definitely better on the right. And then having done that, you put all of those 3 movements together in a nice big over-exaggerated circular motion. So a big sort of over-exaggerated chewing motion. Nice and slowly. That's lovely. If you get a bit of clicking in your jaw, again, that's fine. Don't worry about it, it's normal. Okay, and that's then done. So the exercise is to maintain your swallow during treatment. There's 4 of them. And we do, the first 2 you would only do as practice. The second 2 you can actually use as a swallow strategy. If you're finding swallowing difficult during treatment, you can actually use it when you're trying to eat and drink to help make the swallow more efficient. But the first 2, definitely not. So the first one is gargling. A dry gargle is preferable. So you try and gargle with the very back of your tongue for about 10 seconds and then relax. That was pretty good.
Thank you.
It's quite hard, and it's when you first start off doing these, it's not always clear whether or not you're doing them right. But actually, Jill, that was pretty good. So the second one is to stick out your tongue. It only has to be ever so slightly, but to stick out your tongue, hold it with your teeth and try and swallow in that position. Some people can only get the very front of their tongue out. Some people can get quite a lot of it out. This is basically taking the very back of your tongue to the gym and making it work as hard as you can. And for some people, it's really difficult.
It is.
It is difficult, yeah. Shall I do it?
Yeah.
Because I'm pretty good. I don't know why.
I can't do it.
Mine looks like this. Too many years practice. So those 2 you would not use when eating and drinking. They're just for practice to keep the back of your tongue as strong as it can possibly be to get a good efficient swallow. The next 2 you use for practice, and you would do them after you've done your trismus exercises. And again, you would do them through 10 times each, 3 to 5 times a day. But the next ones you could also use if you were having trouble swallowing during your treatment. These actually make your swallow more efficient, so you can use them as well. So the first one is to really clench the muscles in your mouth by biting down and then swallow nice and hard. Good. And then the second one is to do the same. So you hold your breath this time, really tense those muscles, bear down as if you're trying to swallow a gobstopper, swallow hard, and then cough on the way out. Good. Perfect.
So this device is called a flexible nose endoscope. This end goes down the nose, so we can look down it, either look down the eyepiece or connect it to our camera system, where we can see all the areas that we've treated with radiotherapy and make sure the tumour has responded. So when this goes down your nose, it can feel a little bit strange. It shouldn't be painful, but it does let us get an excellent view of the area we've treated to make sure the treatment has been successful. We would normally do this every time you come to clinic for your follow-up appointments.
My name's Elaine Pratton. I'm a cancer research nurse and I'm going to talk about clinical trials. Doctors use clinical trials to improve cancer treatment and care. They provide the evidence that they need so doctors and patients know which treatments are the safest and most effective. So there's only a small number of studies open locally for head and neck cancers. All patients are considered for studies, but not everybody will be eligible. If you are identified as potentially suitable, it will be mentioned to you by your hospital doctor and you'll be given some written information to take away so that you can read it in your own time. You'll be followed up by a member of the research team just to see if you're interested and talk you through the research process. All participation in research is entirely voluntary, and agreeing to meet with the research team doesn't commit you to entering into the study. Rather, it gives you a chance to ask questions and find out how that particular research project fits in with the current standard of care.